Meeting. We're here in Huddersfield today. My name's Cathy Elliott. I am Chair of NHS West Yorkshire. We are now on to a section of our board meeting in public looking at our system performance. So we have item 13, Integrated Performance Dashboard, our financial performance linked to our corporate risk register. And colleagues, what you also have in item 14 are AAA reports coming from a variety of committees linked to the Integrated Care Board from our 5 places and also from our West Yorkshire committees as well. And I'd like to take it all together because if our governance and our reporting works, it should all complement each other. First of all, I want to invite Lou, then Jonathan, then Laura, just to give us a really brief overview, and then I'd really welcome questions as well as updates from colleagues chairing those committees and leading in those places. So Lou, to you. Would you introduce yourself, Lou?
Hello, I'm Lou Auger and I'm the Deputy Director for Planning and Performance. So the report that you've got is quite comprehensive, so I'm just going to pick out a few bits, reminding you that this is the latest available published data, so there are some time lags on some of the data points. It contains ranking where it's available for each of the metrics, so we can sort of see a comparison. And we've also added to this one the latest GP patient survey results, so just a little summary. You can get the detail through the link. So thinking about the urgent and emergency care performance, we've got a cluster of metrics that cover a number of areas that signpost to how we're doing. Picking up on the people waiting over 12 hours, which is one of the ones that's flagging. This is people waiting over 12 hours in A&E. It increased in July in terms of the length of wait. But I think at the last meeting, I mentioned a piece of work that was being led by the acute urgent and emergency care recovery group looking at specifically this area. And so what I can say is the unpublished and validated data for August and September shows a much better position. So that's not sort of showing in the data because it is the published position. YAS performance against the Category 1 and Category 2 standards is supported obviously by how well acute trusts are doing in terms of handovers, in terms of the A&E front door. And what I can say is we're managing our handovers relatively well, particularly in West Yorkshire. And we are looking at them on a daily basis, hourly basis, through an application that we have called Radar, which is managed through our System Coordination Centre, which will be doing a lot of the heavy lifting throughout winter and keeping an eye on the system. Virtual ward utilisation is below plan. Plan is 80%, but we're at 72.7. What I would say is we're working really carefully to make sure we're using it for the right patients under the right circumstances. So it's not about using all the capacity, it's about making sure that we've got the right appropriate interface for patients based on their needs. And what I can say is in terms of our trajectory for how many virtual ward beds we should have in place, we're actually on trajectory for that. So we're over our target of 379 beds. We've currently got 395. And we'll be looking at that more closely as part of our winter planning. On the electives, I have got to point out probably one of the numbers is rather large. So we're looking at the trajectory in terms of people waiting a long time, over 65 weeks for their procedure. And the data point that you've got in the report is June. Since then, we have halved the number of people waiting that long. So I just need to say that. And we're doing, the trusts are doing a really comprehensive piece of work and I'm working closely with them, looking at the pathways for each of the patients who are waiting and looking at where mutual aid, so where services can be provided in other hospitals for patients and looking at the independent sector. And we believe that we will make further inroads within the next 2 months on that for patients waiting over 65 weeks. ENT continues to be quite a difficult position for not only our trust but nationally. So getting through patients who have got on the waiting list for ENT, and also we've got some procedures around surgical and gynecology that are very complex, which will take some time to clear. Looking at diagnostics, again, we're not quite on trajectory for that, but I think we've made really good strides over the past quarter, and we are actually the best in terms of getting people seen within 6 weeks across the different diagnostic tests out of the 42 ICBs. So looking at the ranking, we do rank well. We've got more to do and we continue to work hard on that. Some of our backlogs are in DEXA scanning, and we've also got some backlogs in audiology, and we have already made some improvements around those. And previously we did have a backlog in echocardiography, but that's now been cleared, so you can see that we are making further movement on that. thinking about talking therapies. Last time we were saying that we weren't quite hitting the target. We're now actually made such improvement over the previous quarter that we're above plan. And then finally, just bringing us back to the primary care access survey, I just wanted to point out that we cannot compare the results of this year's survey that came out on the 11th of July because the questions and methodology has changed. So we can't look at it in comparison to previous years. What I can say is that we are tracking well against the national key questions. The value of this is the local breakdown. It goes down to primary care network. And what I can say, we're taking this through our primary care access group, which are doing lots of work on this and have throughout the year. And our primary care leads pick this up along with some of the local patient surveys that they are doing. Thank you. That's all of the items I wanted to pick out of the report today. I don't know if there's any questions.
Great. Thank you, Lou. We note that GP information, which I think is really helpful, particularly as we can see it by primary care network. And want to hand over then to Jonathan.
Thanks, Chair. So just want to give a brief update on the month for financial position for the ICS and the ICB. So as we noted earlier within the AGM, we did set a challenging financial plan this year for the system in a challenging financial context nationally. So we had a plan as a system for a £50 million deficit for the full year. The year-to-date plan at month 4 was to deliver a £52 million plan. So that is worse than our year-end position. So our plan's profiled in such a way that the position gets worse before it gets better, and it gets better about month 9. And that's related to the efficiency profile that appears largely or to a greater extent in the latter months of the year. So we had a £52 million plan at month 4. What we delivered was a £64 million deficit. So we were £12 million worse than our plan. That position is slightly worse than the position we're at month 3. So not a great position as a system. That 12 million splits into 3 component parts. One is the direct costs of industrial action that we experienced earlier in the year. The second relates to not delivering the level of elective activity in hospitals that we initially expected. And the third relates to operational financial issues, primarily to do with slippage on efficiency schemes, which we still are hopeful will be made up as we go through the year. What we have seen in the overall financial position is that the pay bill across West Yorkshire is falling, but not in line with plan. And it's falling primarily because of the reduction in the amount of money that we're spending on agency costs, which continue to fall and continue to be below the national cap. Notwithstanding that, we have quantified as a system that we are holding circa £80 million worth of risk, which requires mitigation by the end of the year. There are a number of actions that we are taking. They're both set out in the performance report as well as in the Chief Exec's report. And they include enacting the findings from the work that was commissioned recently from PricewaterhouseCoopers by WIAT, the West Yorkshire Association of Acute Trusts. So that's the first area that we are progressing. The second is around commissioning an additional piece of work to look at ICS finances across the board. The third is around enhanced oversight and assurance of the 4 trusts that are in the NOF 3 category that we talked about earlier. The fourth is around further work with individual organisations. And the fifth is reviewing the extent to which we want to adopt some of the more stringent grip and control measures that are set out for systems that are in the most extreme end of financial distress this year nationally. So a number of actions that we're taking. The final area in the report, just for the board's assurance, is that we continue to both deliver and forecast full achievement against our mental health investment standard for the year. Thank you, Cathy.
Thank you. And then Laura on the corporate risk register.
Thank you. Yes, today marks the end of our second risk cycle of the year, and as always you've got the corporate risk register, detail of high-level place risks and risks that are common to one or more places. As part of the learning from our recent internal audit review, all risk owners and senior reviewers this cycle have been asked to focus on a number of areas to improve the articulation and the scoring of our risks. There's more detail on that within the report. We currently have 49 risks. All have been reviewed by either Finance, Investment and Performance Committee or Quality Committee. Just wanted to draw your attention to 3 new risks that are on the register. They're set out at paragraph 3.4. One relates to gender identity providers, the second around passing of patient details to Local Care Direct, and the third around patient choice requirements, and again the details within the report. We have 3 risks that have been closed this cycle. One is a critical level risk, which is we have decided to move to the board assurance framework, which relates to future pandemics, and the other 2 that are being closed have reached tolerance. We currently have 7 open critical risks and 10 serious risks. I particularly wanted to draw your attention to the one critical risk that has increased to that level, 2437, that relates to the potential impact of GP collective action. And you will see within the report that that has been the focus of discussion at both Executive Management Team and the Finance Committee. We've included detailed feedback at paragraphs 5 and 6 on the discussions that took place at Executive Management Team and the committees. I won't go through each point in there, however I hope it gives you assurance that the risks are being discussed and there has been a particular focus on high-level risks. That was all I was going to say by way of introduction. Thank you. I know the value comes from the discussion.
Thank you very much. And then in looking at item 14, you can see there that we have got reporting coming from our 5 place committees, Bradford District and Craven, Calderdale, Kirklees, Leeds and Wakefield, our West Yorkshire committees, Audit, our Finance Investment Performance Committee, Quality, Transformation, and we also have a report from the Pharmaceuticals Service Regulation Committee, which is a committee in common that's met during April to August this year. There are some themes, one around delayed discharge and 65-week waits, which Lou, you've talked about, and also I know has been a point from the Finance Investment and Performance Committee. There is also a continuing reporting around the pressure on services in terms to support people who are seeking asylum and concerns around safety and safeguarding. And we also have some specific alerts coming through from certain committees. I know in Bradford District and Craven, an alert on renal services, for example, and in Wakefield we have a consultation on Pontefract midwifery-led unit as well. So I'm just going to open it up now. We've got some time together. It's our role to have a look at these risks, to scrutinise the performance, but also to give assurance together. But there are some themes there that perhaps colleagues might want to come back on. So we'll go Richard, then Hannah, and then Rachel. Richard.
Yeah, thank you. And thank you for the inclusion of the GP patient survey analysis. I think that's helpful because it only comes out once a year. So I think it's useful to look at that. And I just wonder whether we could maybe sort of, look in a bit more detail over the coming months about why the variation is within some of our practices and PCNs. I think it's quite helpful to see the answer to question 32 around overall experience of GP practice broken down by PCN and link that to our earlier discussion in the board around health inequalities. You'll notice quite obviously sort of, some of the PCNs at the bottom end of that chart are in communities that are more significantly challenged than those towards the end of the chart, but not exceptionally, because there are some within the top ends of that are in very deprived communities. So I think it'd be useful to maybe link that information with patient demographics, but also practice demographics, maybe the workforce, maybe the ways of working. So if we can just try and learn some lessons about what it is that attracts patients to particular practices and through experience, and what it is that we can do to try and address some of that. So it'd be helpful to try and link some of the data sets that we've got. I think the second thing just to say is that whilst we can't compare this year's results with last year's results, generally the themes of this year's results seem to be a lot more positive than last year's results. So I think the work that practices are doing seems to be paying off in terms of making sort of or improving patient satisfaction and experience overall.
Richard, that's really helpful. I'd picked up on that as well as I was looking at the reports in terms of the variation there. Rob, do you want to come back and...
I just wanted to make a suggestion on that, and Ian can either tell me we're already doing it or that we can pick it up in the fuller board or elsewhere. So I think it is striking, Richard, and I think if we look at, as you say, the bottom 5 on question 32 about overall how would you describe your experience. So we've got Bradford City, Central Halifax, 5 Parks, Bradford North and Seacroft, and we'd all recognise that those are areas of significant deprivation. And we do have at the other end of the spectrum Armley and Beeston and places like that, which also face sort of deprivation. Is there any work in train to buddy up the clinical directors from those PCNs or staff from within those primary care networks to see what improvements we could make as part of the fuller board work?
Right. Ian, would you respond on that, please, and just explain what the fuller delivery board is for people watching the meeting as well? Thank you.
Yeah, thanks, Richard, Rob and Cathy. Yeah, so the Full Delivery Board is the board that oversees the work that we do around integration of primary care services into communities in line with our ambition for that work. Three comments. The first one is that it's good to see improvement that we've achieved this year, as Richard has said. That triangulates quite well with the primary care access recovery improvements that we've seen. So we know that we're seeing more people, and we know that there's really good work happening there, and general practices are working really hard despite the challenges around collective action, so that's really good. Second thing I'd say is that this information is used in quite a lot of detail by places. So place primary care teams analyse this data, work with practices, understand variation, work to support practices to improve their position, and that's something that each of the 5 places do, and I think that comes across really clearly in Lou's report. The third thing to say is that I think there is probably a bit of comparative analysis we could do at West Yorkshire level, as Richard's describing, by looking at this by deprivation characteristic and those sort of things, to see if there's anything else that we can ascertain by looking at a slightly bigger sample size across West Yorkshire. So that's something that we can take away. Did you want to come in, Lou?
There's different response rates as well. I think it's about the motivation of people to be able to respond in a 3-month window when the survey's done, whether or not the person's actually been in touch with their GP practice during that period as well. I think that the access group, the primary care access group, which has got each of the place leads represented, is an excellent group to actually take some of this forward. And I think probably with the combination of primary care metrics that we've started to talk about at the Quality Committee and the Finance, Investment and Performance Committee, which sort of rounds it off with other metrics that are linked to our 10 strategic ambitions. I think a combination of those we should probably be looking at, but use that particular group, because I think they're the right people to be doing some of that work. Thank you.
Right. Thank you. James, do you want to come in? Would you introduce yourself?
Yep. So I'm James Thomason, Medical Director for the ICB. So I suppose I'm just going to build on what Ian just said there, and particularly the last point in terms of, okay, what's the value across West Yorkshire? Because as Ian has said, a lot of that work will be looking within our places and actively doing that. But I suppose at West Yorkshire, as you've highlighted, and what we're about to do is we'll bring in a kind of leadership position there to support general practice. And that would be one of the areas we'd kind of be looking at, is how do we kind of share the learning, the feedback, the data that we're seeing here in terms of some of those practices. What are they doing that others aren't doing across our places, rather than just within our places there, and understand that. So I suppose it's building on that, and just to assure the board in terms of kind of developing our leadership, our clinical leadership across West Yorkshire within general practice to help support that. And I think that's where our added value is going to be at West Yorkshire, whereas we know that the majority of what's required in terms of our clinical leadership is in our places there. But here's an example where we can utilise that. So thanks.
James, that's really helpful. Thank you. Rob, did you want to come back in?
Yeah, I just think we need to do that in a way which brings in the learning from the universal healthcare work that we did with South Bank University, and just to test whether those different models, bringing in the third sector and other partners as part of the capacity, will genuinely help in some of the areas where we're not getting the kind of people aren't getting the kind of access or experience that they need.
Okay, so we've got a few actions there, suggestions, further analysis to take forward to the fuller delivery board. So Richard, thank you for that question. We then have Hannah, Rachel and then AC. Hannah.
Thank you. I'm Hannah from Healthwatch. Just 3 points actually. I suppose just to say, as part of the Becky Malby paper that we did a while ago, we talked about bringing these metrics to life in terms of stories behind it and actual experiences behind this data. And I think, Lou, that we've been talking to you about how we might do that. So hopefully that will be coming to the next meeting around that. I suppose aligned to that is around people's experiences of health and care. These metrics are good and useful, but there's something around understanding how it feels for people in terms of receiving health and care at the moment. So on that note, we're just working with Bev and the Quality Committee around developing a regular quality report based on Health Watch insight from across local Health Watch around the key themes that we're hearing. And I suppose just building on that in terms of the GP survey, it's great to see the GP survey reference there. It does mention in the detail it was a small sample size and it was online first. So, you will get certain people that are able to fill in that questionnaire. We've collectively got a lot of insight around GP experience. Variance has been the theme. Some, as we've just identified, some GP practices are really getting it right for people, and some of them there are issues. And if we want to know what are those things that those practices are doing, I think probably we know what some of those things are. Welcoming reception is the fact that digital services or booking systems are working for people. There's themes that people have talked to us about mean that people are getting a better experience. And actually, generally, the general experience is when people get through to the person that they want to get through to, they have a positive experience. It is that access around GP experience.
Thank you, Hannah. We can pick this up in our involvement work that we're picking up again with Paul Hemingway, and we'll pick up with Nadra Mirza, our new non-exec member, but there's also that continued point around the person's voice, the local people's voice, coming through into committee work as well as our reporting as well. Okay, thank you. Rachel, then AC, then Fatima.
Hi, Rachel from Local Government. It was on that risk 2391 around Home Office dispersal of asylum seekers. So I think it probably is timely for local authorities to write again to our Home Office colleagues to talk about how the dispersal programme could be reviewed, particularly in relation to the health impact both on asylum seekers and local systems. But I think it may also be timely for us to invite them to come and discuss with us here in West Yorkshire what being a system of sanctuary is about. We know that some of the things that we've got specialisms here in West Yorkshire, for example, post-torture trauma, female genital mutilation, reconstruction. These are specialist skills that we have here in West Yorkshire that asylum seekers could and should be directed to, but it's not being done in a systematic way, and I think that reflects probably the lack of joined-up thinking that happens at a national level but doesn't happen here at a local level. So I think if I'm happy to ask local authority chief execs to write that letter again in the first instance, but if you're happy, we can also make that offer to come and discuss what that would look like and what better planning for the future would look like.
Thank you, Rachel. I really appreciate that. And I can see reporting from the places, and it's come through our quality committee as well, about making sure those services are available, but recognising the demands, recognising that there are decisions being made outside of the system that are creating pressures on services. Just before I go to other colleagues, I wonder, Robin, I know that you have both your place role as well as you have national roles as well. What are your thoughts there on Rachel's offer to then contact the Home Office, offer an opportunity to come and visit, to showcase what we do here as a system of sanctuary?
Yeah, there's a lot of engagement going on, so we'll take it away and talk to chief execs about how best to do it, I think. Yeah.
That's great, thank you. And that crossed up governmental working, which is very much what we'd like to encourage. We work very well in West Yorkshire in that way, in connecting together. Thank you. We then go to AC.
Thanks, Kathy. Just briefly, and thanks, Richard, for raising that. I think I did mention before as well in the sort of non-exec catch-up that this would be something that we have specifically looked at Finance Investment Committee in pretty detail in the GP survey, specific to the feedback and looking at the variance and where it. So thanks, Rob, for raising that, because it links back to your own report in which 64% online registrations, and then you need to go to 100% as well. I think that links back to some of the spaces, some of the places around Bradford and Calderdale, where there is significant variance in terms of access to GPs practices, on phone as well as online. And I think if we look at the data closely, as Richard was requesting, we might see a correlation there and the overall poor experience as a result of that. So it will be useful to understand where this goes to. I think full of what you mentioned and a response to that. We have had this chat, so hopefully we'll see a response in the next few meetings. And the second bit is that 65 bit, again, a lot of conversation we have had in the meeting. And I think just to assuring that I think we're moving in the right direction, a lot of action has been taken since then. So I think the metric is on a positive trajectory since we last met.
Yeah. Thank you, AC. That's really helpful. Fatima.
So just a reflection, really. I mean, I've gone through the dashboard again, which is really helpful and really detailed, and I noticed that we're probably in the top half on average for most things, if not trend-setting in a number of areas. And I was reflecting on the Darzi report about public expectation and the fact that our system is doing more with less capacity, less people, less money. But if I was a member of the public watching this board, I wouldn't always fully appreciate that. And I just wondered whether we're doing everything we can to articulate the hard work that colleagues are contributing to our health and care system, and the fact that we are delivering really high quality services compared with a lot of our counterparts. That was sort of the first reflection. The second thing was, if we just reflect on some of the data sets that we've seen from colleagues earlier on in the meeting, despite being really impactful in a number of areas, we're still not quite hitting some of the inequalities that we need to meet. So I just wondered whether, although we're hitting targets, we're missing the point, but also there's some work you're doing, Lou, with Sarah and with myself on what we are measuring to demonstrate where those gaps are, and whether there's an opportunity to sort of ramp that up a bit more so that we can really helpfully demonstrate people that are engaging with us to say, well, you're not reaching me, you're not making a difference in our life. But I just thought it was really important to point out that we are doing really well on a number of areas, but because we're quite restless for improvement, we focus on the areas where we've got concerns. I'm really keen, particularly with patient dissatisfaction, that we amplify the stuff that we're doing really, really well, and that we're nationally trend-setting on as well, and wondered whether the board could think about how we do that, because as a member of people that use services in West Yorkshire, and that's me, I want to hear that.
Thank you. So I think that's work to be done afterwards, but as an action. But I think there's also something you're challenging on, which is a similar but different with what Hannah was sharing in terms of people's experience that's going to come through the dashboard as well, Lou. So maybe we could take that away. So thank you, Fatima. It's getting a balance, but we also recognising, which I think I'm grateful, AC, and you sharing your view as chair of our Finance, Investment and Performance Committee about how we're working to seek assurance on improvement, for example, on 65-week waits as well. Okay. I'm going to bring Jane in next, but if there are any colleagues around the table in representing sectors, provider collaboratives, or places that you'd like to contribute something just to provide an update or a development or a question you have of a colleague, please feel free to let me know. Jane.
Yeah, thanks, Kathy. I was just going to comment on the risk section of the reporting. So I think it's great to see how much this is developing. So thank you, Laura, and your team for how you're working with the organisation to get these updates through. And it's really good to see, I think, the comments from the committees and EMT as they have reviewed the sort of, particularly high risk scores. And the sort of responses to that. I guess it's just kind of thinking about how we try to make best use of this report in the board meeting rather than repeat potentially what happens in other committees. I guess there's something when I'm looking at it, there are some areas, some risks that are flagged that are actually issues now. They're real as opposed to a risk, and I'm not sure at the moment we draw that out, because a response to an issue as opposed to a risk should be slightly different. And I think, I'm always one for further enhancing, in terms of how we report it and sort of lead us to have the right kind of conversations. So I think it would be helpful if we can sort of draw out the ones that are really here and now, we are in this, what are we doing and is it sufficient? I think again, looking at the sort of the detailed work, we look about the overall gross risk, I guess, but we also have target risks. And they may come off closed if they get down to target risk, but I'm not sure how effective we are yet. We talk about what we're doing, but that sort of flight path or time scale in terms of what we're setting ourselves to sort of, or are we just accepting that we're going to sit at this risk outside of target, etc. And I think just reflecting on, because there's a lot that are still there. There's a few that come and go each time as it should be, but I would say there's quite a core chunk of very high risk rated that we see, and I think just assessing whether there is more that we need to do, or if we're accepting that's the position for now, so that to frame our conversation, I think that will be helpful going forward. Thanks.
Thank you, Jane. Do you want to respond, Laura? Can I just ask if there's a microphone turned on over there? Would you just turn it off? Thank you. Then we can. Thanks. Laura, do you want to respond to that?
Just to agree, I completely agree with Jane's comments, and hopefully you'll see that that is what we're starting to do. We have prompted around, particularly around where we believe that risks have become issues, to look at what are the risks that fall out of that then, to articulate those. There's definitely more work to be done, so these really helpful comments, and hopefully you'll continue to see it develop.
Okay, I'm pleased that other colleagues want to come in. So I've got Brendan, Robin, Therese and Kira wanted to invite you in. There's a theme throughout the reporting on the demand for neurodiversity assessments as well, so I wanted to invite you in. So Brendan, Robin, Therese and then Kira.
I'm probably only commenting because you asked, Chair, but I probably need to make an... But I need to make an obvious comment, probably, which is behind all of these figures and performance conversations are people. And I think I probably need to assure members of the audience or anybody watching that, you know, we're not sat looking at the figures but not thinking about what sits behind it. These are patients who are worried or unwell. I think this speaks to how we work truly in collaboration as system partners. I think we need to move away from just looking at acute episodes of care versus mental health episodes of care versus community episodes of care. Actually, we need to look at the totality of that. But I wouldn't want to lose sight of the patients behind all of these conversations and indeed their families.
Thank you, Brendan. I think that's then helping us make this more sophisticated and supports Hannah's point earlier on bringing voices of vocal people into our reporting as well to remind us of that. Thank you. Robin, then Therese, then Keir.
Just very briefly, I think Jane's been watching our place committee meetings because we have had a very long discussion about risks and issues to the extent that we're going to do some development thinking about it because it's tricky. My only challenge would be risks become issues, but then they become risks again. It's not a linear thing. But the simple sort of truth, I think, is that most, if not many, if not most of these risks are being played out. So when we look at our risks in Calderdale, social care providers are collapsing. You know, it's in the public domain. It's not. So that's real, and we are mitigating and dealing with the consequences of that. Organisations are potentially not viable because of kind of the budget context we're in. So, however, it's, you know, it's a nuanced thing. It's quite a complex thing. So I just wanted to sort of make that point. It's a dynamic thing, and as long as we kind of keep that sense of dynamism and energy and reflectiveness to it, I think that's the most important thing, rather than almost where it goes.
Thank you, Robin. That's helpful. Therese.
Thanks, Chair. So building on Fatima's ask for some good news, I'm just noting in the BDC report that Bradford District Care Trust, which is my trust, I'm Chief Executive of that trust, has been given £50 million of capital resources from the Department of Health and Social Care to rebuild, not all, but part of our building in Linfield Mount in Bradford. And that building was built and designed in the 1940s and 50s. So it's not the way that we want to provide mental health at the moment in modern day in terms of therapy. So we are fantastically pleased. We can't do everything that we wanted, but we will focus on a number of areas. One is around ensuite facilities. You can imagine if you're feeling very unwell, you are in a very small space with 25 other people who are very unwell and sharing a couple of bathrooms and toilets. So we will make all our rooms en suite, which will make a massive difference. We'll also have some therapeutic space, which we haven't got currently at Linfield Mount, which obviously is going to help people to get well quicker. So we're really pleased about that. Linking to Kate and Susie's piece around people, the environment for our staff working in Linfield Mount isn't great either. Lockers, toilets, changing facilities, also something that we can have a look at in terms of our staff who come to work every day to do difficult jobs and how we provide, you know, better facilities for them. And then finally, something that we're also really pleased about is that we will be able to work with local communities and local people to look at how we can have employment opportunities in the build. work in Linfield Mount in what is one of the most deprived areas in Bradford. So fantastic news. Lots of work ahead. Kathy, I think, has asked me to come to a board development session just to talk through with the board what our plans are and what it might look like. So some good news from Bradford District and Craig.
I'll manage my enthusiasm, but I am so delighted for you. It's fantastic. And I know it's been a huge team effort over many, many years. So, yeah, it is fantastic for the trust, for the place, and for local people and their families using those services. So thank you for that. Keir, I just wanted to invite you to talk about neurodiversity assessments. There's a continuation theme in the reporting today.
Yeah, thanks, Kathy. So a reminder, I'm Keir. I work in mental health, learning disability and autism. So this follows on a little bit from a discussion we had at the Quality Committee, looking into a bit of a deep dive into neurodiversity. First thing to say is that in each of our places there's an awful lot of work going on to try and understand what can be done locally to try and improve waiting times for people who are waiting for autism and ADHD assessments for children and for adults. Predominantly that's trying to work better with what we've got, recognising that actually we recognise nationally, and it is recognised nationally, that there's a significant need for investment in those diagnostic services if we're going to really break the back of the volume of demand that there is out there. It's really increased in recent years. The other thing to say, though, and this is part of our West Yorkshire work, is it's not just about diagnosis. You know, Brenda's just touched on it as well. There's an awful lot about support for people who are neurodivergent, which is not just the diagnosis, but what's the point of that diagnosis and what support is out there for people when they are diagnosed, or indeed those who don't get a diagnosis and still have needs that we need to support. So from a West Yorkshire programme point of view, what we were really clear about this year, the collective work we're trying to do is kind of 4 things. So the first is, can we be really, really clear about what our collective approach to the right to choose agenda is, so people can choose to get a diagnosis through a private provider anywhere in the country if they want to, but how do we ensure we've got a reasonable handle on the quality of that so that it interacts well with our local services? And we're not far off having a single West Yorkshire approach to that now, with a single agreed West Yorkshire quality standards, which feels huge because it's taken a long while to get there. The other bit is about data. We still have a lot of work to do to make the data clear. So unlike a lot of the information that comes here, we will see there is no crystal clear autism or ADHD data. We're trying to do some work in the system about what do we agree we collect and how do we do it. But we might need a bit more kind of national support on that too. And there's other pieces of work around work with schools and wider society. And then finally, we have held a couple, as I think we've mentioned here before, neurodiversity summits with system partners. So not just looking at the diagnostic pathway, but that wider support. So there's 3 things we think we're going to take forward as a result of that now. One is, what do we do across sectors about that issue of support not based on diagnosis? So particularly the value of our VCSE sector partners in supporting individuals who might be waiting a long time for that diagnosis. So what does support look like and what does that wraparound look like? And then finally, can we do more collectively around consistency and kind of screening and triage for autism and ADHD, because it does differ, and how do we deploy some of the digital solutions that makes the assessment pathway more efficient, which I suppose loops all the way back around to Rob's point earlier about the move from analogue to digital. There's an opportunity here to try and do some of that jointly in the same way, really. So none of that is going to solve the issue at the minute, because it's a significant kind of gap, but it's making an inroad.
Great. Okay, that's really, really helpful update. Thank you. James, do you want to come back in?
Yeah, it's just to support Keir in terms of, and the discussion that was had at Quality Committee is showing up in terms of the AAA as well. But I suppose that clinical consistency, there's a lot of work going on that. That's both at a national level and a regional level, but I think specifically we need to make sure we've got it right at a West Yorkshire level as well there. So there are discussions to try and enable that, move that forward from a West Yorkshire point of view, recognising that, as I said, it's not just a West Yorkshire issue there, but I think those discussions are on hand and will be kind of fed back to through the Quality Committee and the committees there. And also, I suppose, also just to kind of highlight some of the discussion at Quality Committee, which is in the AAA, is that one, I think it's important that as we talk about this, that we recognise that there's a difference in terms of treatments, in terms of adult and children, so we need to be aware of that, whilst accepting that there are similarities as well across it, but there is a difference there, so we need to be, when we're describing this, we need to be clear on that, and that obviously has impact in terms of some of the treatments and the pathways there. And then the other thing is that, as in terms of assurance, point of view for the committee here and the board, is that this will be part of some of our focus when we kind of do some reviews within our across our places. It will become a kind of an agenda point there as well. So, and that was taken at quality committee and going to be fed back, so that so the board is assured that we are, in terms of whilst this is happening at place and collectively, that we are kind of hopefully being assured and understanding the challenges and making sure that we're kind of bringing together where we need to as a system, but that's taking place through our place-based focused arrangements.
That's really comprehensive. Thank you to you both for sharing those updates. So I'm going to move us on now from items 13 and 14, but just wanted to mention in terms of our ICB West Yorkshire Quality Committee, thank you to Majid for being our interim chair of that committee for a few months, and Nadra Mirza will take over that chair role in a non-executive capacity from the 11th of November, but thank you, Majid, and I know you'll continue to be a member of that committee as well. Thank you. Okay, we're now going to move on to item 15, winter planning, and looking at seasonal operational pressures. We've got an overview here. Lou, what would you just like to highlight with us, and then we can take some comments and questions.
So I think the plan's it's quite comprehensive, the paper. It's got quite a lot of detail in it. Since the paper was written, we've actually received the winter letter. And what I'd like to just assure the board is that the items within the winter letter align really well with the plans that we've put in place. I think the emphasis really remains on delivering the plans that we've got and bringing us back to those plans. So we're actually doing some targeted work on that. And also, we've currently been put through our paces by NHS England, quite rightly, on the plans that we've got in place and testing them out. So I think that's probably all I wanted to say, and happy to take questions.
Okay, thank you. For anyone who's been paying close attention to our board meetings over the last 2 years or so, we work to have these kind of reports, an update in the summer, a fuller report now at this time of year, and then also an evaluation into March. And I know when we did our evaluation of 23-24 winter, Robin, I remember you saying one of the key things to winter is preparing early. And I'm really pleased to see that you've done some work since the beginning of July. Would anyone like to comment at all or share any points? Hannah?
Yeah, just wanted to check. We had a report last year, and there was a lot of insight from people's experiences around that, and there were a number of recommendations made. I just want to make sure that those recommendations are part of the plans going forward. I think at the time Anthony agreed they would be, but it's just to receive assurance that they are.
I probably would have to I have to be honest, Hannah, I'd have to go and have another look, but they will have been fed into the winter review meeting that took place and then will have come out again. But I will just make sure we've picked everything up to be thorough. Thank you for that.
Great. So that came from the March this year evaluation of our effectiveness during winter, our planning and delivery, which was accompanied by a Health Watch report with recommendations. So thank you, Lou. Mel?
Yeah, it was just to confirm that, you know, a lot of places have been working on the winter plan for months now, and we do insights with all of our partners across the places that we work, and those recommendations and insights are coming from last winter. So in terms of what interventions we put in place, they respond to the recommendations and the learning that we've taken from our winter experience from the year before or the year before that in some cases. So yeah, just give that assurance to Hannah.
Thank you. Fatima, and then we'll finish up on this item.
Yeah, just really briefly. I mean, obviously, it's really important that we learn from last winter, although I don't feel like we ever left winter, to be fair, in the last year. And also just learning from the incredible comms campaign that Karen Coleman and colleagues led on Together We Can. I just wondered, just really taking into consideration the role of trusted influencers and our amazing VCSE colleagues, whether there's an opportunity for us to really collaborate and amplify on supporting people to make informed choices, but also the elements of prevention as well that you referred to in the report.
Victoria.
Thank you, Chair, and thank you for the really helpful paper. It was just a really quick comment, which was related to the prevention point. It feels brilliantly helpful that vaccinations are absolutely in there front and centre, which is obviously the right thing to do. And then on the action plan, there is a line which talks about linking up with local authority initiatives. which again is absolutely right. I just wonder if it would be helpful to pull out the significant area of supporting people to stay warm, the winter warmth. You know, obviously last year there was the high cost of heating, which exacerbated that, and there was a lot of work around warm spaces that joined up locally. It just didn't come out as strongly as it maybe could do in the paper, and I know there's lots of work going on around that. So yeah, that would be my only comment. Thank you.
Victoria, thank you. I support what you're saying in terms of recognising any work that's being done already or could be done in future on fuel poverty. I think there's another element around bed poverty as well, which our colleagues in public health have been looking at with University of Leeds as well, which I talked to your colleague Anthony Keeley about as well, and just recognising these significant issues for certain communities. The other point I wanted to make as well, if our colleague Sarah Monroe, representing mental health services around the table, would say that last winter was the worst winter ever for mental health services, and how we are acknowledging that and then also building that into the plans for this year. I've got Kim and then Richard, and then Lou, we'll come back to you. Kim.
So just linked to the board risk register about the reduction in capacity in communities to divert from A&Es. I expect that playing out this winter, because we do know that there are services that have now gone or will be gone by in the next couple of months. So I think we will see that, and obviously that is a worry. Also, obviously, reports coming back from VCSE colleagues about their increased waiting lists, etc. So previously, where you might have seen the VCSE be able to divert some capacity out into some of the services, that will no longer be the case either. So I think that's just something for us to, to be recognising.
Mm-hmm. And a risk to the plans, and it has to be adapted. Thank you, Kim. Richard.
Yeah, I mean, Victoria said most of what I was going to say, but I think just building on that, I think one of the things that we could do is link in our communications promotion of various warm hubs that exist around West Yorkshire, because not only will that help in terms of warmth, but also address loneliness and mental health and well-being as well. And I think if we can identify those and promote them as part of our own networks, then that would be very helpful. Yeah.
So Lou, there's lots of suggestions, people there to be supportive to the plans as well, so I hope that's helpful. And will you keep us updated, bring us back an update at the December board meeting with Anthony?
Very happy to. Thank you for the comments, really helpful.
Okay, great. And thanks to everybody who's working on this at the moment, because it's not just Lou and Anthony, it's a huge team, collaborative partnership effort. Thank you. Okay, we have 2 more items on our board meeting in public. They are 2 items to approve. In some ways quite straightforward, so I'm going to hand over to Laura. If we could take 16 and 17, that would be helpful. Thank you.
Thank you. I'll start with the ICB Constitution. So the Constitution sets out how we govern our organisation, and we keep it under ongoing review. There are a small number of changes that we've identified as a result of the new model constitution that was published by NHS England in July. They're fairly small amendments. They relate to clarifications on certain roles, tenures for non-executive members. There's updates in line with the provider selection regime, and also the removal of some clauses that existed in the previous model constitution relating to the establishment of ICBs. It's been to Audit Committee en route to hear who are supportive of those amendments, and we're asking you to approve the changes and support an application to NHS England to make the amendment.
Great. Colleagues around the table, board members, happy to nod around the table. Yes, thank you for that. Thank you.
Thank you. And on to the fit and proper person policy. So following a review of the fit and proper person requirements, the scope of the fit and proper person test was extended to include integrated care boards. Today's policy is the first policy for the ICB that seeks to address those requirements and set out our approach to making sure that we're compliant with NHS England policy, and we're seeking approval of that today. Thank you.
Okay, great. And this has, as you said, been to the Remuneration and Nominations Committee and to the Audit Committee?
Yes, members of both have been consulted on the way through.
That's great. So colleagues, are we happy to approve that? Nods around the table. Thank you. I know there's a lot of work behind the scenes and it only took a few minutes, but thank you. I really appreciate that. And the importance of fit and proper persons, well, in the NHS anyway, at board level, but the fact that we are further developing that for the Integrated Care Board as well. Thank you. Rob.
thought it was worth stating for the record that all appointments have included a fit and proper persons test.
Thank you. Right from the start, as we were forming the ICB and this board from January 2022. Thank you. I don't have any other business, so I want to thank everyone around the table for their preparation and their contributions to this NHS West Yorkshire board meeting in public here today in Huddersfield. We also, thanks to those of you who prepared and presented at our annual general meeting earlier today, and thanks to a number of people who've either watched online or joined us here in person in Huddersfield today. Thank you very much. And that is our board meeting concluded. Thank you.